and that we have to stand on our own legs. The country has to move forward, decrease our imports, have our own R&D systems and the implants and everything, equipment and gadgets and reagents. And that's the time that please reach out to them. Even
Camp, now we are developing WHO and Bill Gates Foundation to understand that how practically we can give our compression bandage to lymphedema patients. It appears very easy. You can give me 100 solutions and do all those 100 we have discussed, none will work. And how to give to 6.2 lakh people. So this is one of our missions we are working on this now.
And what type of hospital, like partial or a full L1 throughout the
Inhalational injury, something.
Is 95%.
It is mixed one. It is deep, superficial, and deep. Second and third degree both mixed.
Okay. Fine. And how you are planning to treat her?
So now, first we need to resuscitate her. Hemodynamically, she is stable only. Then we can plan for OT. Otherwise, we will not be able to take her to OT.
And we have seen the vessels arising from it going to the skin that are known as perforators. We have marked the perforators also. So then we have given an incision medially and raised the flap. And
So this was all stuck like this then, right? So
the kind of wound dressing that you have to do on a flap. Does it vary?
yes, we should not put any kind of pressure on this. It will be a very loose dressing.
And
a rural setting where there is only one medical officer sitting, or he may have 2 or 3 staff he is having. All the staff cannot come for a single patient to turn the patient to examine the back. So we'll have to innovate something in a way, maybe straps or something in the spine board, so that a patient who is lying on the spine board can be turned by a single person and whole back can be examined by a single person. So this will limit the requirement of the human resource, which is where we are actually.
There is a time pressure. Somebody is always dying in a busy trauma center. So how much time will you prioritize to each patient? How will you look when there are multiple casualty events?
इसको चलने में और बैठने में बड़ी सारी प्रॉब्लम्स होती है। तुमने हियरिंग एड लगा रखी है?
prescribed as per the government standards. Okay, यहाँ पे we have basically a person is connected to all those monitors, which is monitoring a ventilator. So every bed is a ventilator bed. These are the newer, more portable kind of ventilators. Then infusion pumps and
Because classification, predicate as well as the substantial equivalence plays a very critical role in order to determine the pathway which your product is going to follow. Risk devices, then we have the class B, which is the low to moderate risk, and then we have class D products, which are the high risk devices. Okay. Now the right classification is something which sets the tone for your entire regulator.
these are the scheduled drugs, H drugs, Schedule I, Schedule G. We get sometimes confused between class A, class C, class C and D are invasive. Of course, they are invasive. But A and B, is there a guidance or how will that be approached?
I think the FAQ also says that it is a dynamic list which keeps changing. So depending on the international practices, they are putting it under the different class A and B.
Okay.
From that comes the price of this. From that comes the bill of materials. How much does it cost to make that comes the common. A rough idea. The entire forecast that you make on any Excel sheet or any, let's say, paper, whatever it is debatable. But what's the BC sector has it thought to it? How much does it cost to make? Can the plastic be made locally? Can it be sourced from, let's say, somewhere?
Just wanted to know your, or these kind of technologies we just instead of a random we created that artificial wound bed kind of system.
Have stuck this line and we don't have these generic products in the market yet. Then there was a turning point during my PhD, that was a personal suffering.
So this was a small video I shot and now it will be Innovation in AIIMS, wherein every 2 hours, 2 to 3 or 3 to 4 resources have to come towards a patient side, reposition the patient every now specifically.
Come to this stage. So I have seen with Shivani and I have seen with Ashish that if they talk about their SIV time and their immersion, so they have crossed a very long journey and they have incorporated all kind of feedbacks. That was the best part, and that was I was telling in the ICMR thing also, that the innovator should be patient enough to receive the feedback from the clinicians and keep on do the modification.
But you will be, if you have ever seen a thermoplastic splint, the way it works is you will get a big sheet, okay, and you have to, once the patient comes in, you take their measurement, then you heat it up, then you trim the.
Lost early, and compared to a tuning fork, which is a qualitative device, this kind of quantifies vibration perception, and based on testing in the foot, we are able to predict whether.
He was a retired army soldier. He was getting a lot of foods from different companies, so we thought he is the right person to give us a feedback. So it was just on the day of his fitting, and so far I think it is third month.
So it provides surgeons 6 degrees of freedom inside the abdomen, just like a surgical robotic in a handheld instrument. So the surgeons have increased access inside the abdomen, and with a single click of a button, it takes the bite of a tissue such that
were marvelous. I think all of us benefited a lot. Like we are heartbound, thankful. And just a suggestion for the next cancer, and ma'am, like patent part with Dr. Vijayan was talking, if we can incorporate that, that's going to be a real good thing for the innovators.
Outlook of what's happening in trauma and what are the problem statements in trauma and works, so that like we could also keep our kind of eyes open for technologies that can kind of solve those kind of problems that exist in India. And